Welcome everyone to the August 31st, 2020 COVID-19 clinical rounds on EMS. Today we'll focus on a case presentation. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 clinical challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those clinicians with the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated on these rounds. These are not intended to be or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emergency Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Strubinger and his team for the peer-to-peer learning platform we're using for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. This Tuesday, September 1, will be critical care rounds. Thursday, September 3rd, will be emergency department rounds. Stay tuned for announcements for future rounds. A special note, welcome back. We hope you used last week's time off for rounds for something that supported your mental health and reinvigorated you. We'll continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds we've had to date, we continue to have participants from all states and other countries. We apologize in advance. We're not able to answer all the questions we receive, but we pick out major themes from questions and hope to cover at least some of those. Dr. Strubinger will now go over logistics.
Thank you, Rick. Welcome everyone to today's EMS clinical rounds. I'm just going to go over, as Rick said, a few logistic issues and housekeeping. We really appreciate your questions and comments, and hopefully everyone can see the Q&A button in the bottom of the Zoom toolbar. That's where we would very much like you to put questions and comments related to today's discussion, and we'll be monitoring the Q&A. There is a chat function. If you've got any technical or logistic issues, please put questions there in that chat area. Also, Rick will be asking a crowdsourcing question, and please put your responses to that in the chat. The session is being recorded, and your attendance is consent to be recorded. Thank you for that. The presentation today is going to be shared. It hopefully was shared with the email announcement, but if not, we'll be sharing it on our website within a day or two, as well as a link to the recording of today's session. Also, we're offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. We'll be putting a link in the chat about 15 minutes before the end of today's session, and there should be a link in the announcement that went out this morning. We really appreciate your feedback that you give us in the survey just before you get your instant CME and CPD. So please take advantage of that opportunity and share with us your feedback so we can continue to improve these sessions. These learning sessions are focused on improving patient care and health systems and supporting clinicians. So let's please keep them apolitical. Thank you for that in advance. Just a word about data use. We just want to remind everyone that we keep your data that you share with us when you register, when you answer the polling questions. and put your comments in the chat that it's all kept confidential. We do share de-identified data with ASPR so that they can help better inform the COVID-19 response. Now I'd like to hand over the microphone to Sharon Van Aersdale at Emory University and NETech to give us an update on the NETech education series. Sharon.
Thank you so much, Bruce. Hello, everybody, and happy Monday. It's great to be back. My name is Sharon Van Aersdale. I'm the Program Director for Emory's Serious Communicable Diseases Unit. By background, I'm an ED nurse. I'm also the Director of Educational Resources for the National Emerging Special Pathogens Training and Education Center. And as you heard from Dr. Hunt, it's been an honor and a privilege to be able to be part of these clinical rounds because it allows NETech to better understand what the needs are, where do we want to do kind of deeper dives to complement these clinical rounds. So we do have several webinars that are in planning or already scheduled. We'll be posting those shortly to our website, but we have some coming up on palliative care, as well as a COVID-19 update and PPE fatigue, which we specifically heard during these clinical rounds, like how do you mitigate some of that PPE fatigue? And then we also have remdesivir coming up, behavioral health, and alternative care sites. So please check us out at netech.org. Thank you, Bruce.
Thank you, Sharon. And just want to give a reminder to everyone that the AAMC is a partner in these clinical rounds, and they have been maintaining and building a wonderful coronavirus clinical guidance repository that is updated on a weekly basis. So if you're looking for a one-stop shopping site where you can find updated clinical guidance and other resources related to COVID-19, the AAMC site is an excellent one to go to. So with that, Rick, back to you for the crowdsourcing question.
Crowdsourcing question, this was not hard at all right? Last week, we took a break from rounds. So it was with purpose. You were supposed to use it for that time to take care of yourselves. So what did you do during the time you would have spent participating in rounds? I'm hopeful to get some good answer. Don't be creative. I mean, like, tell what you actually did. Don't get like way out there. So before I introduce our speakers, there's one quick announcement or sort of addendum to the upcoming schedule. I should have mentioned when I was reviewing the upcoming rounds that we're going to take another day off. Goodness, we're going to take Labor Day off, as it should be, and I'll stop there. So no EMS rounds next, I think it's next Monday for Labor Day. Before I introduce our speakers in our traditional fashion, I'd like to have each of the panelists please unmute yourselves, and we'll go around the Hollywood squares, starting with Dr. Kramer, and if you please give us your name, affiliation, title, and affiliation. John.
Hi, I'm John Kramer. I'm the Director of the Office of EMS, the National Highway Traffic Safety Administration, and the team lead for the HHS Healthcare Resiliency Working Group EMS Prehospital team.
Thanks, John. Carol?
Good morning. I'm Carol Cunningham. I'm the State Medical Director for the Ohio Department of Public Safety, Division EMS.
Thanks, Carol. Dave?
Gerstner or Tan?
Gerstner.
I'm David Gerstner. I'm with Dayton Fire Department in Dayton, Ohio, and I'm their regional MMRS coordinator for a 10-county region in West Central Ohio.
Thanks, Dave. Rob McClintock?
Hi, Rob McClintock. I'm the Deputy Director of Fire and EMS Operations with the International Association of Firefighters.
Thanks. Dan Gerard?
Dan Gerard. I'm the President-elect for the International Association of EMS Chiefs, and my day job, I'm the EMS Coordinator for Alameda Fire.
Great. Paul?
Paul Bittinger. I'm an emergency physician and director of the Mass General Center for Disaster Medicine.
Garth?
My name's Garth Gamer. I'm medical director of Phoenix, Glendale, and Surprise Fire in Maricopa County, Arizona, member of State Trauma Advisory Board and State EMS Council.
Thanks. Dave?
Hi, I'm David Tan. I'm an emergency medicine physician and chief of EMS at Washington University in St. Louis and president of the National Association of EMS Physicians.
And Doug?
Hi all, Doug Kupas. I'm an EMS and emergency physician in central Pennsylvania with Geisinger Health System. I'm also the state EMS medical director for Pennsylvania, and I'm on as a member of the NMSP board.
Thanks all. With that, I'm going to turn this over to our speakers. I'll introduce our speaker, Beth Adams. Beth is the quality manager for Fairfax County Fire and Rescue Department in Fairfax, Virginia. Beth, welcome.
Thanks, Rick, and thanks for inviting us to be part of this. My co-presenter today is John Winstead. John is a technician in our fire department. The case presentation we're doing is a patient he cared for. John's been a medic for 14 years and been with Fairfax County Fire for 5 and has proven himself to be indispensable, both helping with paramedic interns and as an adjunct instructor in our academy. And thanks again for inviting us to be here. So without further ado, Fairfax County is pleased to be part of this presentation. And I bring greetings from John Butler, our fire chief, who also is a paramedic, and as part of his welcome to the county speech, cited being the first person to do a crike in his agency. So he's got good street cred as a medic. Fairfax County is home to 1.2 million residents packed into 395 square miles. Among the notable residents of Fairfax County is the Honorable Rick Hunt. Under normal times, Fairfax County also picks up an additional 500,000 plus each and every day as they arrive to work across the tech and service industry, which is heavily based in our area as well. Fairfax County Fire is a combined career and volunteer department. We have 38 stations with the 39th nearing completion. We have 7 battalions, and interesting to note, we have an ALS provider as minimum staff on our front line, transport units, engines, trucks, rescues, and tankers. 460 of our 1,300 uniformed folks and 300 plus operational volunteers. 460 of them are authorized paramedics in our system. We have 2 full-time medical directors, and both of them are certified, board certified in emergency medicine and EMS. We run about 100,000 calls as an agency a year, and as is typical for most of America, 70% of those are for EMS. With regard to COVID, Fairfax is not, we're the second bastion out from the District of Columbia, but we are considered part of the metro area. And so early on, we've been tracking what's going on around the world. Our agency issued their first safety bulletin in January, and that was advising people of what was known then of symptoms, what was known with regard to with PPE guidance, which is interesting to note at that point in time, if someone presented with an acute febrile respiratory illness, both the provider and the patient were being masked with an N95. And it also contained guidance about reporting exposures and decon and follow-up. A short couple of weeks later, we updated with additional symptoms, which were better known and becoming more widely available. And at that point, we said, providers are going to wear an N95, but the patients are going to just wear a procedure mask. It was about the same time or shortly after that we were collaborating all the way along with the County Health Department, the Office of Emergency Management, and across the 50 plus agencies in the county. But things really escalated on March 10th when we had our first confirmed case in Fairfax County. At that point, by that point in time, we had already implemented call screening at our dispatch center, and they were providing information about infectious risk in the dispatch messages. We were at that point in time already tracking N95 usage across the county. In short order after that, the Governor Northam, who is a pediatrician, declared a state of emergency for the Commonwealth of Virginia, and we were off to the races. Within 2 days of that, our incredible and intrepid data analytics team had set up the graphic that you see in the middle of this slide with a dashboard for COVID updates that has since been replaced with a SharePoint site, which includes all things COVID specific to the fire department. So there's resource guidance, PPE tracking, links with regard to HR and wellness issues, what the current status is with hospitals, where the clusters are in our congregate living centers, as well as other related information. We have had a dedicated deputy chief since mid-March, whose job it has been is to be the czar of all things COVID. And they have provided SIT reports and updates on an as needed and continued basis. Now I'll hand it off to John to tell you about his patient.
So this call was dispatched at around 8 p.m. Back on June the 3rd. I was assigned to a transport unit, and as is the usual for our jurisdiction, all ALS calls receive a ALS first response vehicle, which for this instance had to be a aerial ladder truck, as well as my medic unit. The information that we received was that the language line was used for a Spanish-speaking 47-year-old Hispanic male who had a known positive infectious disease case. Complaining of shortness of breath, and also we were notified that he was not responding normally. As you can see in red on the screen, our CAD is set up to automatically highlight in red that CPPE is recommended, notifying all the providers that our COVID-19 personal protective equipment needs to be donned prior to making patient contact, and our alterations to our normal assessment protocols need to be changed. And they also voice that over the radio, which has become the kind of constant thing you hear all over our dispatch frequency, unfortunately. We knew that we were going to a second floor garden apartment off of the dispatch information. And there was also included that there was no known history or anything else. Our changes to the way that we've been making patient contact, both originally because providers kind of came up with the plan on their own and then became protocolized throughout Fairfax County, was to don our PPE appropriately and attempt to screen the patient from a distance, either from the doorway or if they're able to ambulate, have them come out into an open air environment to decrease the number of providers making contact and to begin our assessment there. With the information given that the patient wasn't responding normally, we went to the patient's bedside and weren't able to request that the patient move on their own. Once we arrived on scene, we found an adult male who was moderately dyspneic. He was able to speak in 2 to 3 word sentences. He was standing when we arrived and was able to ambulate short distances, although he did remain pretty profoundly tachypnic, breathing about 60 times a minute. We found out through interview, as well as using our language line to be able to do a translation with the Spanish-speaking male, that he had had a positive COVID-19 PCR test back at Virginia Hospital Center in Arlington about 2 days prior, and he had been sent home because he was able to maintain saturations, able to walk around without desatting, and they told him to monitor his symptoms from home. Over the last 6 hours, the family and he reported that he had progressive worsening of his symptoms, primarily being shortness of breath and fatigue, not actual altered mental status. And our initial patient contact was made with our COVID kit, which you can see a picture of on the screen. We've taken some of our previous infectious control fanny packs that all providers were issued and have reallocated them with a finger pulse oximeter, a thermometer, whether that be our infrared contactless thermometers or our tympanic thermometer that's listed there, and then the surgical mask for the patient. And some of our providers have started throwing our non-invasive capnography into that kit so that we have to unmask fewer times to be able to do our full assessment. So we made contact with this gentleman, determined that he was ambulatory for short distances, but when we put our pulse oximeter on, realized that the RAD57 was showing us that his sats were below 50% at room air, and made the decision that we were going to bring a stair chair in and not have him further exacerbate this by having him walk down a flight of stairs. So appropriately masked him, coordinated with the crews that were on the exterior of the building that were in the pseudo cold zone, and able to get him down the stairs on oxygen. As you can see on the screen here, a list of our after patient contact vital signs, and this is a little bit of a delay actually from when we got into our transport unit, but you can see that our initial pulse ox was 62% with a good pleth waveform, and that actually was on 15 liters already by non-rebreather. And we'll talk about our treatment in just a second, but you can see on that first row, really not any significant change in oxygen saturations that we would expect to see by throwing somebody onto 15 liters. The only other remarkable things to look at was the patient's respiratory rate held in the 50s the entire time that we were with them, and in the Untitled remained about 15 the entire time. So no major changes to his capnography. Blood pressure, the rest of his vital signs, tachycardic, but no real other major changes associated with his blood pressure. So our initial pre-hospital care plan was to put a non-rebreather mask on with a surgical mask over top of that. Because of the type of CPAP that we use, we don't have the ability to have a filter that actually captures the exhaled side of our disposable CPAP. So we don't have non-invasive currently as an option for us. So as I said, moved him down the stairs via stair chair with that ongoing oxygen, continued our assessment, and then due to where he was located at off of Route 1, he's very close to one of our community hospitals, I know Mount Vernon, so about a 6-minute transport by ground. One of the things that we've really focused on has been early notification of the receiving facility that they have a patient under investigation or a suspected COVID-19 case, so that they're able to spin up their resources appropriately. And this particular emergency department has their isolation rooms just inside of the ambulance entrance. So as soon as we make that notification, they're able to then coordinate us quickly moving into their isolation rooms, minimizing our flow or wait. If we don't make that notification, there is some time with registration as well as the normal flow for patients coming through. Because the patient continued to remain pretty profoundly hypoxic during our transition into the ambulance, we did bump that flow rate for the non-rebreather mask up to 25 liters per minute. Partially just to see what would happen if his sats would improve. And it obviously did not make a big difference for his tachypnea, although he didn't really have any increased work of breathing, and we didn't see any changes to his pulse oximetry. The only other major things that we did was get a peripheral line established, but held off on fluids, held off on any medications, and really were just trying to set the hospital up for success, knowing that this guy was going to have a pretty long hospital course. Wanted to see if there was going to be any major changes with our 12 leads. Initially, when our providers started taking care of these patients due to infectious control, they were concerned about getting inside of the bubble with the patient too close, but I think that we've overcome that pretty significantly. So getting a good 12 lead, really nothing remarkable here. Didn't see any type of ischemic changes or any other weird ectopy or anything that you would expect to see from somebody who is this profoundly hypoxic, even on high flow oxygen. So realizing different disease process, something different going on. And you can see our Untitled CO2 waveform at the bottom, other than the fact that he is tachypnic and has the rounding that you would expect to see just from that rapid respiratory rate. No real major changes, no bronchospasm associated. So luckily we have a good working relationship due to Beth's shop with Inova, Fairfax, and all of the hospitals in our area. So we were able to find out the eventual course for this patient. So he was admitted for 24 days. He bounced in and out of the ICU and step-down unit at Mount Vernon. He was actually admitted not only with a positive COVID-19 infection and respiratory failure from that, but also in DKA with viral sepsis, which I don't know. The area that we work in, we do have a fair number of patients who do not really have a good healthcare plan and ongoing primary care. So whether the diabetes was an underlying thing that he just didn't have a previous diagnosis of or good management of, I'm not sure. But that was one of his comorbid factors on admission. They managed, obviously, the DKA, started him on remdesivir on day 1, and he started off on BiPAP in the emergency department, but was then changed over to high-flow nasal cannula with proning as he got into the ICU. He did get stepped down from the ICU into one of their mid-level units on day 5, but day 13 wound up having a additional escalation with their rapid response team, and they ruled out a PE for him. Eventually, on the 27th of that month, so like I said, 24 days later, he was able to be discharged to home, which looking at a lot of our cases that we've had a number of folks that have been discharged back to nursing facilities or had, unfortunately, non-successful discharges. But this gentleman hopefully is going back to a normal lifestyle afterwards. So our information is listed here with any questions or thoughts. And Beth, I'll turn back over to you for any additional thoughts that you want to add in.
John, I think you did a great job covering the case and describing what we've done in Fairfax. So we'll hand it back over to Rick and the panel.
Hey, thanks, thanks, Beth and John. It was great to hear about the system. And John, great case presentation. I'm going to open it up to the panelists for their questions. Well, I have, as I do that, and raise your hand for questions. As I do that, one question in terms of like the transport destination, how is that? Has that been changed at all since COVID? How you're triaging to various hospitals in the region, or pretty much stayed the same, is based on capacity, or how is that? I mean, the bottom line is, what I'm trying to get at is, yeah, a long way around of why was the patient transported to that community hospital as opposed to tertiary for this particular patient? And I've got like 5,000 reasons, but I'm interested to hear yours.
The benefit of kind of Fairfax County as a whole and the Northern Virginia region kind of all dealing with COVID at the same time is that they've not really specified any specific hospitals to be receiving these patients. Mount Vernon actually has become one of those really well equipped just because it is a newer remodeled emergency department. So they have very, very good isolation negative pressure rooms that are right next to the emergency department. They've really emphasized, because of our proximity to DC, having the ability to deal with hazmat and those types of things. So that's been our primary from my battalion where we're transporting to. But all of the health systems in the region have been doing a good job where they realize if they need to be stepping the patient up to and including somebody needs to go up to Fairfax or a different hospital for ECMO, coordinating that interfacility, but not really putting the onus or responsibility onto the pre-hospital provider to decide, do I need to go somewhere else out of the ordinary? It seems like they've all, even though we have our trauma centers and our cardiac centers, everybody has stepped up to the plate as far as COVID management goes, which has been nice that they've been able to kind of share their census.
Yeah, no, that's exactly what I was looking for. And it's actually really encouraging to hear. So others, yes, Carol, yes, I see you.
Oh, that's okay. The National EMS Scope of Practice model has now added high flow oxygen nasal cannula to the scope. And I was curious, with your EMS agency, as well as other folks listening in, has COVID accelerated your department's consideration of possibly purchasing the equipment for high flow nasal cannula and to use pre-hospital?
Beth, I don't know if you want to speak if the medical directors have had that discussion. I know that the EMS equipment committee that I sit on for Fairfax has not really pursued that. However, at another agency that I moonlight at, it has been looked at just due to our longer transport times there. We're a rural agency with about 45-minute transports. So it's been looked into. Getting the devices and the technology has been a challenge for us because, of course, everybody is looking for all those airway supplies.
Yeah, I don't recall that we've had any detailed conversation about it. It may come up tomorrow at our division and budget planning meeting, but It's been discussed, but nobody's done a deep dive on it that I'm aware of.
Thanks. Dan, I think I saw your hand up.
John, great presentation. Two questions. One, do you do proning of non-intubated patients in the ambulance? And then my follow-up question is, for this patient that was treated, initially seen and discharged home to monitor his symptoms, are they given fingertip pulse oximeters to monitor their signs and symptoms? And again, great job.
Thank you. We've had discussion as far back as early March about proning of our non-intubated patients, and obviously there are some challenges associated with trying to keep them appropriately secured. The challenge with this patient obviously is the language barrier and trying to communicate what we want them to do. Kind of the general consensus that we've come up with is encouraging the patient, hey, find a position of comfort. If you're not being successful, if you're not feeling like you're getting better oxygenated, then we're telling folks, hey, try rolling over onto your tummy. The one thing with our agency is most of our transport times are sub 15 minutes. So the timeline and the benefit that may come from that, especially the non-intubated patient, I think we're focused more on let's safely get them to the hospital, and then hopefully they can switch them over to non-invasive or high flow or whatever the next step needs to be and come up with that. As far as the discharge to home, this patient had not been sent home with a finger pulse oximeter, and I don't know whether, again, language barrier playing a factor into really digging into what he had dealt with. I don't know whether that had been encouraged. However, I have run into other patients that have been told, hey, go to Walmart if you can find one of these, if you can get it off of Amazon, snag one and keep track. And the only patient that I have run into who had that, their guidance was, perform a walk around your home. If your stats are decreasing, then we need to potentially look at bringing you back into the hospital. But we are seeing a lot of these patients with the initial test, and then 3 or 4 days later calling again with significantly worsened symptoms and not really a clear care plan as to when are they supposed to return. I think that's gotten better recently, but in the initial surge back in March, it was very unclear and people really didn't have any good guidance on when do I need to come back to the emergency department.
John, Dr. Kramer had his hand up.
I'll just follow up on Dan's question, and John provided a perfect response and sequela. Question really for the rest of the panel and the audience folks if they want to respond in the chat box. But, you know, folks have talked a lot about the proning component to it. And I wonder how many EMS agencies, as John alluded to, encourage their patients to find a position of comfort and acknowledge that that may help them if it's on their side or turning over, and really allow them to do it. So more a question for everybody else to get an idea of how common that is out there, because you hit on it very nicely, John.
Yeah, Doug Kupas.
So Rick, I guess I will give my opinion to John's question. Then I did have another comment, and I'm interested in John Winstead's opinion on something also. You know, John Kramer, my feeling on the proning is it is difficult in ambulances. This is my own personal opinion. You know, it's rather difficult to do that in ambulances, but I think that the goal is really to get parts of the lung functioning that aren't necessarily functioning. So if somebody's been laying supine, you know, just getting into the full upright position as much as they'll tolerate it is, you know, probably helpful, but then still allows you to monitor and care for the patient, and possibly turning to a side rather than full proning in the ambulance, only because of the difficulties. I think I've seen critical care crews move patients in a prone position, but that's often after they have been, you know, quite well, they're stabilized as much as possible at a facility and they're being moved by critical care. For Fairfax and John, one of the things that struck me was your use of the end-tidal CO2, and I've been a big proponent of end-tidal CO2 in wave form from the earliest days for the purpose of preventing the error and what I view as a never event of misplaced esophageal intubations, but I think the adapters and using it on an endotracheal tube are a little different than using the nasal cannula use, which many agencies I don't think do. So I'm curious about your, as a field provider, which thank you for your presentation and great to have a field provider doing a personal case like this, but what did you view as the value in this case, and how does it differ from your regular use? I'm wondering if you viewed it as trying to determine if they had some reactive airway disease and needed a bronchodilator and didn't really want to get into lung assessment to the extent that you might in a patient pre-COVID, or is this something that your system has been using all along? And is there a value over lung sounds and other parts of our assessment that already tell us some of these things?
I think it's a combination of a couple of things. Our agency has really heavily pushed using Untitled for quite a while, for all the reasons that you already alluded to. The nice thing that we're able to actually graphically display if we are treating long. I think that in this particular case, so you mentioned, it allows us to provide that better assessment without having to get right up in front of the patient. I've also, and this is impure, completely anecdotal opinion, not based off of us actually doing any type of RCT yet, but it seems that in these patients that are this profoundly tachypnic, despite the fact that they're not having any changes to their waveform morphology, those with either a normal Untitled CO2 value between that 35 or 45, or if they're retaining CO2, despite not having any other type of changes, it seems like that's got decent prognostic value. And how much should I go back with him down the road?
John, we're kind of losing your connectivity here.
All right, let me see if I can turn off my video and see if that'll help.
Yeah,
if
much
that,
better.
Okay.
Rewind the last minute or so.
Sorry about that. Like I said, we've been using it for quite a while. Diagnostic value with being able to rule out that reactive airway side, especially we've really eliminated a lot of our use of bronchodilators that are inhaled due to the aerosolization issue. But it seems that we, at least from my opinion, this is not based on any true data, but it has seemed to have some type of good prognostic value of if we're putting somebody on a type of CO2 and we're seeing that they're breathing 50, 60 times a minute and they're still having a normal CO2, that there's much worse lung tissue issues than one, at least. That's what it appears from looking at the patients that we've gotten follow-up on and seeing what their hospital course was. So this guy breathing 60 times a minute and blowing his CO2 down, good, healthy lungs doing what they're supposed to do, that seems like, although he still had a 24-day hospital stay, there may be some value to that pre-hospitally.
Thanks, John. Stay on. Do what you're doing without the video, because you get broken up sometimes. Beth, are there any points that John made or was trying to make and it was garbled that you want to fill in? Or he's done a great job. He really has.
He did do a great job. We are. He's right that we have been pushing capnography. Certainly early on, it was all about the intubated patient, and heaven knows that's critically important, but we are moving towards doing capnography with the built-ins with the nasal cannulas, so that we can get capnography on everybody, and trying to push the concept that capnography is part of the vital sign set, at least getting a baseline and telling us where we're going. And John has done a lot of work in his role as an adjunct and with our interns, helping to deliver that message about how we can get a much better picture of how our patient is doing by looking at the platform in addition to everything else that we're seeing with our patient, making sure that it all tells the same story.
Thanks. I've got there are a couple questions from our participants I want to make sure that we address. And as said on every one of these rounds, we have a really broad audience. So some of these, for instance, I'm not sure, but it might have come from a non-EMS provider. How would you, parentheses, EMS, have managed the patient differently if he'd gone into respiratory or cardiac arrest? And obviously, as it pertains to COVID, knowing that he's a COVID patient on the front end, how would you approach that? Beth and John, I just don't know. Yeah, John, why don't you give it a shot and see how the audio goes, and then Beth, back up. Okay, go.
Okay.
If you mute me, that's completely fine. So we've really started to heavily emphasize minimizing the number of providers directly on top of the patient. So we're trying to move towards an automated CPR device. We use the Lucas device, but getting that in place early. We have successfully gotten viral filters for all of our bag valve masks. So whether we're placing a supraglottic airway or whether we're intubating with video laryngoscopy, whatever the airway strategy is, attempting to adopt a strategy that keeps us as contact limited as possible. We haven't adopted any specific agency-wide protocols on things related to airway management other than using those viral filters and using a supraglottic airway, but there has been a lot of discussion between providers from person to person that if an intubation is required, if a supraglottic airway isn't working, then using a continuous suction technique like the salad technique to try to redirect any aerosolization that's going on away from providers. The only other big thing is after getting that automated chest compression device in place, trying to work in an open air area, which my area that I operate in is a lot of these guard department complexes, which has been challenging to figure out what would an open air environment look like for them, because we can't really move to a yard easily. We can't really move them into a large space because they're small just by nature. So from not a lot of changes from a medical standpoint for us, but from a logistics standpoint of trying to minimize the amount of providers that are in the non-ventilated enclosed space without some type of protection in addition to what they're wearing PPE wise.
Thanks. I want to do another question that came from a participant, but I want the panelists to raise their hands in response to it for this one. And it's about, well, I'll ask the question. Don't raise your hands yet, but I'll give you the context. I think, EMS sees, EMS sees patients at a point in time. It's frequently very short, certainly in rural areas, but the question is the lack of significant increase in O2 sats despite increased flow rates, a common finding or unique to this patient. And I guess the context for me when I saw that question is like, okay, for EMS providers who haven't seen any COVID patients yet, should they expect when you crank it up to see big improvement, or based on your experience, not so much? So let's help others. So raise your hand if indeed you see big increases in O2 sats when you go ahead and crank it up. David. Yeah, David sees it. Yeah.
See, most of our patients respond to supplemental oxygen.
They do.
Maybe
Okay.
we've been fortunate there, but.
Okay. Any others?
Rick, this is Doug. I think you need a third answer to that, which would be sometimes, because my experience is that especially with COVID, some of these patients have a significant bump up in oxygen when you go to high flow oxygen, and some of them don't, like this patient.
Right. So the sometimes, and Marianne, I saw Marianne indicate that indeed, yeah, most of their patients do. So it sounds like there is like some variability there. Somebody, Garth, you raise your hand.
Yes, I agree with Dr. Kupas. Everybody behaves a little bit differently. What we saw early on in the pandemic, before we really knew what we were dealing with, is our people were calling us out to the scene and say, well, this guy was in distress, but our oximetry didn't work because the patient was registering between 40 and 50% SATs, and they said, well, he looks too good to have that, so we just kind of winged it on the way to the ED. So it became very clear very early that these people would quote unquote tolerate very low SATs, but it is a sphincter tightening experience to try and nurse somebody all the way to the emergency department when you're only getting from say 45% to 60% on high flow O2, but you accept that given mentation, end-tidal CO2, and all those things. Somebody talked about it earlier that end-tidal CO2 was very helpful in taking care of these patients. That is indeed correct. A steadily rising end-tidal CO2 indicates that you need to take control of that airway.
Thanks, Garth. Thanks for a really robust discussion. I mean, it was a great case presentation, great discussion. I see a lot of feedback, folks are finding value in this kind of presentation rather than some of the other ones that we've had before, where it's basically tell us about your system. So we're trying to do some mix of different types of presentations in the future. So thank you. I want to go to the polls, and as I do, give you a little bit of background on the polling this time. As you, and we have talked about on the rounds, but also has been talked about certainly in the healthcare resilience work group at HHS, the workforce challenges. So some of the polling questions you'll see will be very focused on workforce and some of the challenges and some of the work to improve that situation. There are many of you who are likely not in EMS, and there's in the polling questions, there is the option of I'm not involved with EMS, so please answer that one, answer all the questions. So can we have the polling? Yeah, great. Okay. So this is around hiring difficulties, okay? And if you take a look at each of these questions, there's like at the very bottom, there's not affiliated with an EMS organization. So if you're not, that you have the option. And people have gotten great about responding to these. So read them. I'm not going to read them out loud. But what factors are contributing to hiring difficulties in your EMS organization? And yes, it's select all that apply. Well, there's about 5 of these, and these are not like simple yes, no ones. So we're going to take some time and making sure people have a chance to respond. There's about 37% of you have voted, so it would be great to see some more responses here. All right, about just a few more seconds and we'll stop. Okay, let's stop. 53% of you voted. That's great. Thank you. And it looks like the most frequent responses were to low recruitment pool, not enough people seeking jobs, too few applicants to posted positions. And then there's the issue of the graduates too, not enough graduates. All right, thank you very much. Next question. How have financial hardships impacted staffing practices at your EMS organization? And there's the option of you haven't experienced any financial hardships. Hopefully that's a high response, but not optimistic on that. And then there's the not affiliated with EMS organization option as well. This one, as well as, you have multiple options available. And while this is the EMS series of rounds, we'll be also asking similar type questions with similar answer options for inpatient, for the hospitals as well. Okay, another 5 seconds and we'll stop. Okay, you can stop that one. Thank you. Well, this is F. Our organization has experienced financial hardships, but they have not influenced staffing. 35%, most frequent response. How about that? All right, next. So when your EMS organization uses longer shifts or more shifts to compensate for staffing shortages, what is the biggest consequence? So it's a single response here. For those of you who have all volunteer EMS organizations, there's a question coming, so don't feel neglected. Probably about 10 more seconds on this. 53% have voted. I really appreciate the participants jumping on these. All right, let's stop there. All right, 14, let's see. Staff reports of burnout, 33%, the most frequent response by far. 14% don't use longer, more shifts. Also see the increased absenteeism at 7%. All right, thank you. Next. So this is about if you are doing longer shifts, how is your EMS organization mitigating issues observed with longer shifts? Increased staff support programs, increased support for EMS clinicians' families, offering enhanced overtime compensation, offering annual financial incentive programs for staff who commit to working the increased cycles, offering, boy, there's a lot here. So there's multiple options available. And I think there's one or two more questions, and then we'll go around to the panelists for final comment, and then our speakers for their final comment. And then we'll end. All right, 5 more seconds on this one. All right, let's stop there. Looks like the most frequent response, well, no mitigation practices, but then there's offering overtime compensation, 12%. I'm going to keep that up there for a minute so people can have a chance to look at it. All right, and then last question. Yeah, this is volunteers. Since COVID-19, the number of volunteers in our EMS system or organization has decreased a lot, decreased some, stayed the same, increased some, increased a lot, don't know. We don't have volunteer staff or not affiliated with EMS organization. Okay, we got 50% voted, another 10 seconds and we'll stop this one. People are jumping on this one really fast. It's great. All right, that's great. Let's stop there. And it looks as like 17% said decrease some. I'll let that stay up for, let's let that stay up for just a few seconds. And John Kramer, as you've taken a look at these as they've been popping up in the results, any comments, reactions to what you're seeing with these?
It's interesting, Rick, because each time you popped up a question, another question came up in my mind in response to the way people are, the way the audience is responding. It's going to be really interesting to be able to look at the hard copy and look at the breakdown. My take-home message is we've still got a lot of work that we have to do for our personnel.
Yeah. Yes, indeed. Yeah, it's fascinating. The one that really, when I look at this particular one, I see, 2% said increase. Yeah, there are two individuals, but still 2 said increase some, 2 said increased a lot, which I'm fascinated by. So anyway, all right, well, let's take the polling down. Let's go around the Hollywood squares, and I'll start with Dr. Kupas. Doug, any comments before we close?
Rick, I think the only thing that I wanted to say in addition to what I said earlier was that, you talked about EMS seeing a patient at a point of time, and I think that's a fascinating thing. We worry in EMS when we see somebody with these low oxygen saturations and they look sort of good, and we feel like that oxygen saturation is terrible, and in the next 8 minutes while we're going to the hospital, we have to get it up above 90. But the reality is that patient might have had that low oxygen saturation for a day. And, I think we have to sometimes be a little more pragmatic about some of those things. On the other hand, in almost all the agencies around me, I think that patient would have been on CPAP, and I understand that Fairfax said that they don't have a way to capture the exhalation from that. But I think that, in many systems are saying, well, we should do proper PPE and do what we normally would do, which would be put them on CPAP. On the other hand, other agencies are saying, well, that's an increased risk, and let's just maximize the oxygenation and get them there. So I don't know what's right or wrong, especially by the fact that he might have been that way for a day. So the extra CPAP blowing it around does not necessarily mean that it's going to make him better.
Thanks, Doug. And as you say, that point in time, and I think about that a lot. don't know how that ever got ingrained in me, probably on some rounds while I was an intern, but I am just so impressed with the follow-up information that Beth's system, and I know many others have figured this out, but unlocking for the care of our patients, not just to give, for example, to John, well, let's do feedback on a patient, but really help the quality of our EMS care through that kind of follow-up to figure out what actually has happened. I mean, it's invaluable. So good on you, Beth, and your system, and John. That's really extraordinary. So Paul, I know you got the 1 o'clock, so I'm going to try to get to you, and then I'm going to go. Marianne, I'm going to go to you. Oh gosh, Marianne has to go. I was going to get to Marianne before.
Sorry about that.
I got okay.
I can.
No, I'll tell you what.
Hey, yeah, it's great to see everybody's faces. I've got to jump to another call, but the good news is I think we are seeing EMS providers begin to take things more seriously, wear their PPE. We are seeing a fair amount of mental health issues. You mentioned burnout in the survey. We're definitely seeing that. So the key is we're providing some resources for our providers, and really go to LA area fire chiefs. They have a wonderful couple videos on mental health resiliency. So just thought I'd mention that, and that's something we're working on now with our workforce. Thank you.
Thanks, Marianne. Paul?
Yeah, I think coming back to the oxygen saturation question, I think, my hospital has a particular aversion to the term happy hypoxics that's been used from time to time. And there's really nothing happy about being severely hypoxic, at least from a physiologic standpoint. I think, the difference between who responds well to oxygen and who doesn't is important. And at least in our experiences has had a lot to do with who we think is going to get acutely worse in the hospital setting. And so I guess I would draw the parallel to hypotension and trauma, that for a long time, I think sometimes we didn't pay as much attention as we should have to that pre-hospital hypotension value, and the data has clearly showed that was a mistake. And I think that data from EMS, what is known in the field about the hypoxia, whether it does or doesn't correct with oxygen, is extremely important. It's really important to make sure that gets into the minds and hands of the hospital providers that receive the patient, because that persistence of the data, I think, tells us a lot about what to expect with the patient's course. So, no matter which way it goes, I think it just shows that importance of the EMS hospital link.
Thanks, Paul. Dan Gerard and then Garth.
COVID is an unforgiving teacher, and it may take us 10 years to figure out why these people have incredibly low SpO2s, but they don't have tachypnea, et cetera, until they, get to a number closer to 0. And we're working our way through. We'll figure this out over a period of time. Unfortunately, I don't think it's going to go away anytime soon.
Yeah, Garth, thank you.
I noticed on the surveys that there was a lot of concern about staffing, and I have those same concerns as well. EMS was a tough field with quite a bit of, let's say, attrition before a person's working years are completely expended. That was a phenomenon before COVID. Now I worry about people just getting burned out, searching for other alternatives. So it's very important that we provide initial training classes for those people who are motivated. I know it's tough to do with all the social distancing needs, masking throughout classes, et cetera, but it's really got to be done. And that's kind of how our approach is at Phoenix Fire. We've got to try and keep our training program robust, and it's tough to do.
Yeah, thanks, Garth. Dave, Tan.
Well, yeah, thank you very much again to John and Beth for a great presentation. And I would say that in a number of previous clinical rounds, we've seen how PPE does work when appropriately used. And so having said that, when it comes to the patient care philosophy, I would be of the camp that says if a patient you're seeing at a point in time needs a particular treatment modality, use your appropriate PPE and treat them the way they need to be treated.
Thanks, Dave. Rob McClinic?
I just really want to thank John and Beth for the presentation. It was awesome. This platform is great to discuss and have all the doctor's opinions on patient care is phenomenal. And I think it's very helpful to the people who are viewing this, but thank you very much.
Thanks, Rob, for joining us. Dave Gerstner?
We've had a lot of the same discussions about CPAP that Dave and Doug mentioned. We probably would have tried CPAP at the scene for this patient, but even with good PPE, even with PAPRs, the back of an ambulance is a different environment and it's very closed in, and we have real concerns about CPAP on a known COVID patient inside the ambulance. Now at the scene where you've got a fair amount of fresh air, that's a different matter. But we again don't have filtration capabilities, so we are. I won't say we're not doing CPAP at all. It's a large region, and a lot of things are done differently from place to place, but people are reluctant, and I'm not sure that's not an appropriate choice.
Hey, Rick, can I comment on that real
quick? Sure.
I think Dave brings up a really good point. I think that's totally reasonable to say, what can we do to mitigate those risks and try to do something like whether it's nebulized beta agonist therapy or CPAP on the scene. That seems very reasonable to me. I would wonder, however, if that was working and the patient was getting better, or when you see them and they clearly need positive pressure ventilation, it's going to be very difficult most, at least speaking for most of my providers, to look at somebody struggling to breathe and say, well, I'm not going to give this to you. And I'm certainly not suggesting that that's what Dave's folks would do, but I think most of our personnel would accept that risk if the patient really needed it and they were dependent on this modality, if the goggles and the PPE, N95s, et cetera, to do it as safely as possible. I totally agree that if they don't need it, they've been like this for a week and can make it to the hospital, that's one thing. But if they're struggling, that would be hard.
Dave?
Sorry, I completely agree. And of course, it's not a toggle switch, it's a continuum, and it's a judgment call. But I think there are some very important considerations on both sides of that call. Another great opportunity to have a useful discussion. These calls, the echo calls, have absolutely been terrific, and I'm so glad that we have this forum available.
Yeah, the tough part is we don't have. I mean, we don't have the randomized controlled trials right now, and so it really is this kind of discussion that has to take place. And what I'm concerned about is EMS systems, organizations getting insular and not seeing what others are doing and sharing that experience. And that's, to me, the reason to keep the platform going for now. Because, you can have really strong opinions and not see the other side pretty easily. You got your protocol and we're done. And right now is not the time to have premature closure of diagnosis, for sure. So anyway, sorry for the pontification there. Carol, go.
First of all, huge thanks to Beth and John. I think it's great to hear the experience from the providers. With the recent discussion between Dave and Dave, I agree that a patient needs a therapy. It needs to be administered. You can't have somebody just gasping air like a fish out of water. But there are other factors that need to be considered. We've heard from a big department. I live out in the middle of the woods where I'm curious to see what the volunteer or the more rural departments' experience are when you have a long transport, as well as the ability to get a squad back in service to decontaminate it if that's your only ambulance. I still think you need to make the right decision for the patient at the time, but realize that there are other factors too that will impact an EMS agency on their ability to respond and get back in service. But thank you, this has been wonderful.
Thanks, Carol. And John and Beth, you did the heavy lift on this. John, any final comment for everyone? And then to Beth.
Hopefully my internet will hold up. I apologize for those issues. But no, thank you for the opportunity. And I completely agree with the discussion back and forth and really weighing that balance between positive pressure when you can't come up with a filtration system that's going to work versus what they need. And I think our training programs do make a big factor with that. Luckily, some of the more rural departments in Virginia have a little bit different equipment and able to provide that therapy when you're looking at that 45 minute to an hour transport. So very, very good thoughts and discussions overall. But
Hey, thanks, John. Beth?
I would just like to say thank you again for the opportunity to tell the Fairfax County story. I know many of the people who are part of this Hollywood Squares, and so it's great to see all of you. And above all else, one of the things I closed all of my weekly reminders to my paramedic interns over the last 6 months with is be as kind to yourself as you are to your patients. We need to take care of ourselves even as we wear our mask, wash our hands, and do the right thing each and every time on each and every call. Thanks again. Be well.
Thanks, Beth. Thanks, John. Just before I close, want to remind people about tomorrow's rounds. We've talked about mental health. Every rounds we talk about mental health. We talk about taking care of ourselves. Beth, thanks for this, for the strong, important message. We actually took action last week by not having the rounds. And for those of you who okay, you did the QA. I saw people were doing QA, QI during this. No, come on. But then there were people that were doing Laura, and I like Harry's doing a wildfire. Okay, you get a pass, but you have to take a break. Dave Gerson, that counts for you too. Okay, I mean, seriously. I mean, life is short, and let's not shorten it anymore. So that's the lecture. Now, for tomorrow's rounds, this actually was one of the toughest ones I've recruiting for. We're doing one on death of a clinician tomorrow. The Mercy Hospital intensivist, chief of ICU at Mercy Hospital in Baltimore. Hopefully there's going to be a chance to honor him, but also his interim replacement is going to be speaking on rounds. So if you haven't registered for the critical care rounds before, that one, it's not just about honoring, but also part of honoring death of a clinician during COVID, I think, is actually learning how to take care of ourselves better as well. So encourage you to do that if you can. Then lastly, to our participants, even the 137 that have hung on this long, your troopers, always there. And I mean, you're so great with the responses. I mean, when I say 50% respond to a question, that's, I mean, a polling question, really, that's pretty darn good. And then to our panelists, just awesome discussion. And to our speakers, John and Beth, really, you kind of like paved the way for our doing some more case presentations for EMS. So with that, and thanks to Echo, with that, we'll see you on the next one. Over now.